for you to keep either your certified dentist certification or your diplomate with the American Academy of Dental Sleep Medicine. And so we're very excited to have this opportunity to get together and learn and be able to get all our continuing education done also. So I'm going to make a few announcements while we're letting people join in. Tonight, we are going to do the first in a series of courses addressing more challenging cases in dental sleep medicine. We will also be doing some review over some of the past courses, so that way all of the information and the terminology and the lingo is starting to become part of your muscle memory. It makes it much easier for you to do this every day. Dr. Dunbar is going to talk about some of his proven protocols for combination therapy, which is kind of new to a lot of people unless you've been to his office and watched him practice. So it is a really cool system for using what's called an interface, and that helps connect the oral appliance with the CPAP machine. It's a treatment that he has developed over the last 25 years, and he's treated over 900 patients successfully with this system. We're going to talk about patients who have really, really severe obstructive sleep apnea with the AHIs of 30 to 140, compromised dental conditions, CPAP intolerance, multiple comorbidities, cases previously considered untreatable with regular oral appliance therapy alone. And so we're going to have a lot of fun. If you have questions, put your comments over for us in the comment section. If I see something that he needs to address immediately, we'll stop him, but we will have time for questions and answers later. If anybody's interested in the study club and getting your hours, it's $250. You log into the website and then log into your personal site. You'll find a link to the study club. Then you just need to complete, it's really simple. You just complete the survey and the quizzes online. Then you will it'll let Eric Northey know, and he will then generate your CE certificate. If you have any problems with this, or you have any questions, if you will email us, we will be sure to address that immediately. It's very simple. You'll really love it, and it's a good way to get all these CE hours knocked out together. All right, our next person that's going to present, I covered that really fast. Eric Northey is going to talk about the Texas Dental Sleep Services DSM Practice Certification Program for a few minutes.
Thank you, Jennifer. So if everybody here knows me, we expect to have a few more people join. It's December. It was my idea that we did the study club in December, and shame on me. We won't do it next year. I do want to just briefly go over what is our TDSS Dental Sleep Medicine Practice Certification. And this is 24 CE hours. It takes 6 months to get through. Early, the first couple of months, it's a consultation. Every 2 weeks, the consultations will be no more than 30 minutes. You will have homework, you'll have material to go through. The goal of this is so that by the second month, you're able to be seeing patients, dental sleep medicine patients in your practice. The goal is also to establish 5 SOPs in your practice that are scalable, meaning at first you're just going to spend a little bit of time on them and learn how to implement the SOP, the standard operating protocol. Over time, you'll do more and more of that, and you'll grow your dental sleep medicine practice at your pace and the amount of time that you want to invest in it. So that's the goal of that program. It's very well structured. We've gone through our second iteration of writing it. We're going to do one more iteration. Well, we'll do multiple, but we've got another iteration, another version of the material coming out over this month. And so if you're ready to get started with that in January, that'd be great because you can begin doing that program and really see great results from it. That's all I've got, Jennifer. So why don't you pick it up and introduce and get Dr. Dunbar going, okay?
I can get me back. I will. There we go. All right, guys and gals. Dr. Dunbar is getting ready to talk to us about the difficult case part 1. Hopefully all of y'all had a chance to review the material he sent out ahead of time because it was very extensive, very, very well put together. And I think you're really going to enjoy the presentation tonight. Dr. Dunbar, do you have any questions before we get going?
Not at all. Let me
All
get my
right.
on here.
All right.
There we go. Want me to start?
Yes, sir.
Okay, tonight's going to be the difficult case part one. This is, I'm excited about this type of therapy. I've been doing it for 25 years, and it's really treating the untreatables. When you have this, what this is going to address is when patients come into your office and they've got exceptionally high AHIs or they have exceptionally different medical histories, the medical field can't treat them. So you're really the last stop. And I've yet to really not be able to treat in some form or fashion most of these patients over the last 25 years. So to that extent, it's exciting. You're able to use your imagination and you actually see the results very immediately when you're treating patients. As an example, before we get started, I had a consult yesterday with a gentleman who's 41. He's about 30, 40 pounds overweight, ex-military, he's a veteran. And his 3% desaturation indices, which is an approximation of an HI, is 53. We don't even have a sleep study through the VA on the gentleman, but that gives me an indication of what's going on. But I did a pre-treatment baseline high resolution pulse oximetry, and I've actually done three of them. And one of them, his CT90, which is a time above 90%, should be 99% or more, one was 53% and the other was 13%. So that means that during the night he was below 90% oxygen level on one oximeter test. It was below the amount of time needed, but it's still an indication for 87% of the night. And you can't hold your breath to 95%. So in essence, if we couldn't do this type of therapy, he'd go untreated. And of course, research shows untreated apneics live up to 20 years shorter lives. So being able to treat someone like this to me is exciting and is very beneficial. It's a clean dollar bill. It's a good office production. At the same time, it's a tremendous benefit for the patient. So let's go to the next slide. So what we're looking at when we define the challenge, looking at the cases that'll walk in the door, I've treated patients up to with an HI up to 140, low oxygen, which is the nadir, down to 40%. Actually, I think it was 41%, and high pulse rate and pulse rate variation. Now, last study club we talked over with oximetry and pulse rate, when you have a patient who within 25, 30 seconds their pulse rate jumps 20 to 30 points, that's not normal. Or having a resting pulse rate between 90 and 120 or more when they're asleep isn't normal. Actually, those are precursors for AFib. So when you have these patients come in with these type of situations, it's either going to be standard CPAP or nothing. The other aspect is I had a patient, one of my patients came in today, fully edentulous on the maxillary arch, could not afford implants. I've developed a technique that was published, I think in 2017, for fully edentulous patients without implants. I've been treating them for 2 years now, fully controlled with combination therapy and with the denture that I made, and we have no implants. When you're looking at all the publications you'll read say you need eight teeth or more. Well, I don't agree with that. I've treated patients that have had the two lower cuspids and a bicuspid floating in the breeze. And we went ahead and made an appliance, very stable, no issues. When he lost the bicuspid, I went ahead and just used chairside uh, um, reline, hard reline, and the patient was fine. Also, I've developed a technique for treating patients who are undergoing Invisalign or who want to do Invisalign at the same time we need to treat them for sleep apnea. This enhances the ability for your office to maintain production and still meet the patient's needs. The other comorbidity challenges that you have, I've treated patients with Lou Gehrig's disease, Parkinson's, Huntington's chorea. Um, these are, well, Huntington's chorea in part and Lou Gehrig's, the end result is what the end result is. So what you're really doing is making them more comfortable. And actually on one of the Lou Gehrig's cases that I had, we had a respiratory tech in the office, and I'll go over what an ASV machine is, but basically we got the patient controlled. Fibromyalgia, one of my mentors called it skinny woman's disease. You'll have patients come in, mostly females that are between 20 and 40 great shape, looked terrific with some degree of fibromyalgia, chronic fatigue, and there's always an airway component with that. Those can also be the most difficult patients to treat. Let's go to the next slide. So what are our learning objectives? We're going to discuss on how to identify the compromise case, how to choose an oral appliance, what to decide on the materials to use, what's the treatment protocol, understanding the difference between CPAP devices. You have to know about CPAPs and how to modify the case when you get a unique situation. When we're talking about a unique situation, I had a patient who had such heavy drainage, he couldn't wear the lower unit. So we'll go over how I treated him very successfully. Okay, we'll go to the next slide. So what we're looking at in combination therapy. Combination therapy can be CPAP and surgery. As y'all know, UPPs used around 2000 to 2010. UPPs were really the big thing in the field, and of course they don't do them anymore. Didn't really work. We have CPAP with conventional oral appliance therapy where you just put the CPAP mask over the face. Well, most of the patients that you're going to see don't want to wear CPAP, so just adding the material is kind of counterproductive. You can do surgery and oral appliance therapy. That's what we say the Inspire technique or some degree of UPP or layup. Most of those are going to be post patients that have had that surgery in the past, or CPAP utilizing the interface. Next slide. So we're going to kind of navigate through our therapeutic spectrum here. It's going to be really a clinical guide for the devices and how we use them. Next. So what does CPAP do? How does CPAP work? Essentially what you're doing is you're going to, using a mask or nasal pillows or nasal mask or full mask, you're going to pass enough air through your airway, nose and or mouth, to create a pneumatic splint to blow the airway open. You're going to need to blow the tongue out of the way. When you're looking at CPAP, one of the major issues here is the amount of pressures that you're going to be using. So it really works by just creating a pneumatic splint in the airway, opening it up with enough air pressure. And it's kind of funny because to a certain degree, you can stick a leaf blower in your mouth, it'll do the same thing. It's a little cruder, but it's the same concept. Next slide. So what types of CPAPs are there? I'd say probably about 10, 15, 20 years ago that we used to only use plain CPAP. You get a patient in, they put them on 8 centimeters of water. Pressures for CPAP are measured in centimeters of water. The average CPAP you're going to see is usually about 8 centimeters. When you start to get up past 12, you can blow the leaves off the driveway and your compliance rate really dips. So you have standard CPAP that was set at 1 inspiratory at 8, expiratory at 8. Now we have the auto unit, which basically is going to fluctuate with what you need. So if you need a little, the machine will go down to say 6 or 4 or 5. If you need more, it'll go up to 10 or 12. Just depends on what you're requiring. The BiPAP, that's where you require so much air coming in to create the pneumatic splint, you can't exhale. It's uncomfortable. So you'll get a high inspiratory pressure, then the machine drops, and you'll have a lower expiratory. The next one is going to be a BiPAP ST. ST stands for spontaneous timed. And usually if you'll see on the sleep study, they'll say BiPAP ST 5 backup breaths or 10 backup breaths. What that is you're going to get a high inspiration, low expiration, but if there isn't an inspiration, the machine's going to breathe for you X number of times it's ordered, 5 or 10 or 8, is backup breaths during that minute or during that time period. So it's got a backup breaths for you if you haven't breathed within a specific time frame. The ASV machine, auto servo ventilation, effectively just breathes for you. So when you're dealing with someone with Lou Gehrig's, someone who's got severe central sleep apnea, which is usually from a brain impact, traumatic brain injury, you're going to have an ASV, and that's really out of our territory. A respiratory therapist is going to deal with that, and it just breathes for you. So The foundational support for CPAP, it's going to be consistent to basically stabilize a consistently collapsing airway. And you need to realize that when you're looking at any type of therapy, it's empirical. You're guessing. With CPAP, they're guessing at pressures. With an appliance, you're guessing with jaw position. Always realize that your airway from your hard palate to your vocal cords can have an occlusion in the high, middle, or low position from your front to back, side to side, circumferential, full or partial. Then throw in the tongue resting position. There are a lot of variables and a lot of wheels in motion. Most occlusions are going to occur around the oropharyngeal area, about where the uvula is. And also, the lower the occlusion down towards the hypopharyngeal area, the harder it's going to be controlled, whether it's CPAP or whether it's going to be an oral appliance. Actually, an anecdotal situation about, oh Lord, 15 years ago, Kent Jones and I did actually the first drug-induced sleep endoscopy case in Central Texas. It's called a DISC procedure, DISK. And what it is we put the oral appliance in the patient's mouth. No matter combo therapy, nothing took care of CPAP. We couldn't understand why. So we went ahead and Ken took him to the operating room. I went in there with him. We ran a camera up, down through his nose, down uh, into his throat or the airway with the appliance in, and we titrated the appliance. And what we found was his epiglottis would not open very far. It was a hypopharyngeal occlusion. So there wasn't anything we could do. There is a surgical procedure called the repose procedure, which can mitigate that. It's not really consistent, though, in result. And it's kind of a gross procedure in my mind. You put a screw up underneath your chin. You take a needle that's several inches long with somewhat kind of like fish line, run it through the base of the tongue, come back, then run it back through the other side, hook them onto the screw that's been centered in the mandible, and pull the whole base of the floor of the mouth forward. Now, needless to say, our patient didn't do that, and it doesn't give a consistent result, but that's how you can treat a hypopharyngeal. Let's go to the next. Now, Adaptosur, the auto adjusting machine, the nice thing with this is if you set pressures at X and Y, say the lowest machines go is 4 centimeters of water. And as I said, CPAP is measured by centimeters of water. So normally I'll set pressures, and we'll go into it later, at a range depending on different variations. But that's what the auto adjusting machine does. It adjusts the pressure using an algorithm and senses when you're not breathing within a certain time, and then it'll kick on with pressures high enough to break the apneic event. Next. Okay. Most patients today use the AutoPAP. Really, I have found over my 6,030 years in the field, when patients start to hit around 12 centimeters of water, that's strong enough to start to be able to blow the leaves off the driveway. Your compliance rate drops dramatically. When you're around at pressures of 8 centimeters, we can usually match a CPAP without a problem. 9, it's a little iffy, but still, you're going to go ahead and be able to get a good result comparable to CPAP. The ramp feature on all CPAPs, you'll have kind of like a little plate that has power, and to the side, you have somewhat of a button. And what a ramp does is it'll drop the pressure. So if your pressure started at 8 and the patient's going, my brains are being blown out, it's too strong, you hit the button and it'll drop it down to, say, 4, which is a very light amount of air coming in. And then you set the ramp at a time frame. I found 15 minutes to be adequate, so that during the first 15 minutes trying to get to sleep, that pressure is going to just gradually increase to what your initial settings were. So that's the ramp feature. Bi-level pressures, that's really when I've had patients come in where their pressures are in the 20s, low 20s. We've been able to knock it down 50% at least. But once again, when you have a pressure of 15 or 16, you can't exhale. I mean, there's just no way. So you'll have a BiPAP pressure. It'll show like 15 and then a slash 8 or 15/10, where the inspiratory is going to be 15, the expiratory is going to be at a pressure of 10, 12, low enough to exhale, but still high enough to maintain a patent airway. And it's listed when you're looking on sleep studies. Inspiratory pressure is going to be listed as an IP, expiratory is going to be listed as an EP. Go ahead to the next. So with the BiPAP ST, you're looking at spontaneous timed breath given after your normal breathing. And the machine will pick up on that. And this is where you'll have on your sleep study, it'll say BiPAP ST or pressures 15/10, 5 backup breaths. So that means that within that time frame, 1 minute, the machine's going to back it up 5 breaths they found from the, and this is usually going to always be after an in-lab sleep study. They found that the patient normally stops breathing a certain time period within a minute, so they'll put the backup breaths to counteract the amount of breaths that weren't seen during that time frame during an observed sleep study. And of course, the adaptive servo ventilation, that the machine's just breathing for you.
Dr. Dunbar, question on that. What is the difference between that and a regular ventilator, or are they the same?
A regular ventilator, you mean like ancillary oxygen?
No, like if they were in the hospital on a regular ventilator, is that similar to this or different?
Yeah, the ventilator is going to be a CPAP machine of whatever type. If you've got someone with a brainstem injury, they're on ASV. It's breathing for them. But so yeah, it just is going to depend. I mean, these are ventilators. It's just going to depend on what type is being used.
Thank you.
So to kind of summarize, CPAP, continuous, one pressure in, one pressure out. Auto, it's going to adjust to what you need. BiPAP, it's going to have high amount and it's going to lower so you can exhale. The ST, you're going to have a backup breath determined at the 16 channel, or the PSG, the overnight sleep study, to make sure that if they're seeing consistently 5 times a minute you're not breathing, they're going to put the time breath there to make sure you're taken care of. And then the ASV is going to completely breathe for you. Your application, okay, no, that's fine. No, you're good. How does an appliance work? Actually, what you're going to be doing when you bring the jaw forward, all we're doing, it's kind of funny. Whenever I've lectured, I've always compared, I've called an oral appliance a hamburger. And every hamburger's got a slab of beef. All we're doing is simulating with a mandibular advancing device, the CPR move with a mechanical entity here. So a hamburger's got a piece of beef. Every appliance is doing the same darn thing. We're bringing the tongue forward, simulating the CPR move. But every hamburger is going to have different buns, different condiments, different spices. So we have 150 plus appliances in our field that are doing the same thing. They can either pull from the front, pull from the back, hold the tongue down, you name it. So in essence, we're mimicking the mechanical jaw thrust, simulating the CPR move, which increases the tone in the tongue, the genioglossus. At the same time, you're pulling the hyoid bone up to support the muscles of the airway, and you're increasing your sagittal distance in the airway more than you are the anterior posterior. That's what we're doing with this. Go ahead with the next. So why are we using an adjustable versus the monoblocks? About 25 years ago, there were monoblocks out there. A monoblock, you're set in one position and that's it. And essentially, you're kind of guessing where you should be. Now, I may have been doing it wrong for 31 years, but I have found after 6,000 cases that most all cases are treated at maximum maximum protrusive movement, the mandible, just before or just after. When I read things where they're going, well, my patient's taking care of 70% of maximum protrusion, I don't believe it. And a monoblock, you're just kind of guessing to where 70%, 80%. It depends on the patient's anatomy. So the adjustable appliance allows you to titrate. And it's like I had a patient in today, and their normal position might be 3 millimeters past end on. Well, they're going to go to a New Year's Eve party, have 5 beers. You think they need to come to 3.5 or 4 millimeters that night? Yes, because you're going to have to increase the tone in the genia glossus. Same as if you're taking Benadryl, you're taking muscle relaxants, pain medications, late night meals. So the MAD can really adjust to meet the patient's need. The other aspect with this is when you're dealing with combination therapy, you need an adjustable appliance in order to prevent mouth venting from CPAP. And that's something we'll go over at a later, during more, farther into the presentation here. The monoblock has no capability for that. Next. So the key advantages, I wear combination therapy. I've worn it for 11 years now, and I've yet to miss a night. And so what you're in fact, what's interesting is I had a patient in yesterday. He was supposed to come in. FedEx lost his case. And I told him, I called, it's a physician out of courtesy. I called him and he goes, well, he's 80 years old. He's still practicing. He goes, well, I was in St. David's this weekend because I had a TIA, transient, he had a stroke. And so when he came in today, because of what occurred, I made him a MyTap immediately just to take care of him until we get the real appliance in there. So combination therapy, he may or may not need combo therapy down the road, but here again, this is where you're combining a temporary appliance with a real McCoy. With the combo therapy using the interface, you have full freedom of movement. I'm like a chicken rotisserie when I sleep. I'm all over the place. I have no tension whatsoever. I'm not rolled up in the hose, and I hate CPAP and will not wear it, but with this, I've not missed a night. You don't get leakage, period. And your jaw movement is minimal. We'll go over how to determine that, but it is really, really minimal. All you're trying to do is create or stop from any mouth venting with the air. Your therapeutic pressures is an example myself. My therapeutic pressure is 12 to 13 centimeters of water. When I wear my setup, it's 8.5 to 9.5, which is like taking a nice deep breath in the morning. It's very low. You don't get any facial markings. You get females that come in, or males, mostly females will complain. Fair complected, redhead blondes, and they've got the mask on. They wake up in the morning with a nice indentation around their face. That's not real cool. Or you'll have issues with women with thinner hair and they've got the strap on the back of their head that makes them semi-bald over a period of time, pulling the hair out. And anecdotally, there are no studies. I wish there were, but there aren't. I have found that we get improvement using the interface and over standard CPAP alone. This is what the interface is. It's a chair-side TAP-PAP interface. It's adjustable. We've got something set up for the interface itself. It fits on the TAP appliance. And we've got it set up so that members get discounts on the interface itself, and actually discounts on the lab itself for the TAP appliance. We go to the next one. So when we're looking at a procedure documentation checklist, in fact, I had a case today, I had to call the doctor to get documentation. You're going to have your initial soap notes. You're going to have a prescription or order. A lot of the dentists or a lot of the physicians here in Austin will send you a referral. Now, referrals are good for CPAP, and they're just used to CPAP, and their computers are set for referrals. But a referral on an audit will not work. You have to have it as a order or a prescription. So if you have a referral and you go, well, I've got I was referred, this is my prescription, United Healthcare audits it, you'll be denied. So this is where we do have our customary prescription forms, which I developed, has been through 2 lawsuits and 2 times at the state board, and it's excellent. So it does work, but that's what I'd highly recommend everybody use. Initiating the combination therapy, you're going to either have it when you, like a patient comes in uh, with an HI of 80. I had a lady come in with an HI of 82, cardiac case, history of TIAs. I mean, I just said, you're doing this, or else I don't want to treat you because I'm not going to be held responsible. So you have the initial scenario where you're going to go ahead and put it on at that first appointment. By the way, we got her within one night to an HI of 4 from 82 with combo therapy. And or some of the cases will go, a number of my cases will go where the patient comes in, they've got an HI of 28, 30. They go, well, no real cardiovascular issues or medical comorbidities. And so I just go, look, why don't we try the appliance first? And then if it works, great, where we want it to be. If not, we can always add on. Or one lady I've been seeing for, I think, 20, close to 20 years. Her CT90 was the last oximetry we did before we put her on combo therapy was 10%. She was below 90% oxygen 90% of the time, and she felt relatively good. Once we treated her, I mean, that woman would follow me through fire. She had no idea what it was like to actually get oxygen in her body. So you can either add it at the time or add it at a later date. Next. So we've already gone to some degree over the monoblocks. There's no adjustment capability, minimal capability for the resting. When we're talking about combo therapy, there's no ability for this to adjust for a resting tongue level, which is paramount. And realize this, in the past, I've gone over some things like the Bernelli and Venturi effect and Pasuli's law. Realize with Pasuli's law, any movement of the jaw's impact on the airway is to the fourth power. I just had a case where we moved the patient a half a millimeter forward, and their pulse rate went from 90 to 100 to normal, and their oxygen level went from 80, CT90 went from 83% to about 99. So a half a millimeter when you're looking on a fourth power is massive. It's not just a matter of, well, I'm kind of here and kind of there. And this is where a monoblock or the Boylan bites can really, to me, they're useless. Next. So the clinical edge, kind of a recap here, is full freedom of movement. And your two complaints with CPAP, by and large, is going to be, I can't move around without getting leaks. It gives me a claustrophobic issue here wearing it. Mostly you'll find that with women, and particularly blondes and redheads. And then also the fact that you get the leaks. When you move, you get the, on each side of the nose. It drives people nuts. So we're lowering the pressures up to 50%, minimal leakage, minimal mandibular movement, no facial markings, and anecdotally, we get an improved treatment efficacy. Now, I'll kind of throw this out dealing with the mandibular movement. And this kind of bucks the issue here with occlusion. I'm a nut about occlusion. But breathing is a little more important. I mean, I've had patients that could eat steak with no teeth, fully edentulous. It's kind of hard to go without breathing. So I've had patients and I've had doctors get upset over issues with the bite. I don't really have a lot of trouble with it, but occasionally you do. And I'll always go back to this aspect. I ask the patient, can you eat what you want? Yep. Have you missed a meal? Nope. You comfortable? Yep. Your bite works. It may not be the prettiest, but you know something? You haven't missed a meal. And they all like, the layperson loves it. So what we're now going to look at is the documentation records. Your foundational records here are going to be the initial soap notes and the prescription for the oral appliance. Most of the time, you're not going to get the prescription for the combination therapy on the initial prescription. If you've got a really severe case like an HI of 50, 80, 100, 120, this is where you kind of help, you can really help develop your referral sources by talking with a physician. And when you ask for a prescription, you can have them write on the prescription that we've got through TDSS just to write combination therapy. Some doctors will say, I've got doctors when I want to do something, they just go, Martin, do what you want to do. Others will say, look, I only want to have 8 to 15 for pressures. Great. Put that down on the prescription. Or others will say, you do what you want to do. It's an auto unit. There's no issues. So when we're going to integrate the combination therapy, once again, we can add it on the original. It can be added on that prescription, or you're going to get an extra prescription for it. And with the extra prescription, it can be just on their regular prescription pad. We don't need anything fancy. It's an order. And they're going to order it on their prescription pad, combination therapy, and set pressures if they want. I would also, in your documentation, you're going to want to put, I don't really, because I've got all ResMed and Respironics CPAPs in my office. I'll go over that later. But you can put the type of positive airway pressure CPAP used. By the way, CPAP stands for continuous positive airway pressure device. You're going to want to put the CPAP pressures that you're setting it at. You're going to want to put the ramp time if used. You're going to put the EPR, which we'll go into, or flex. And you're also going to put the humidity of what the device is used at. Let's go to the next one. So on the prescriptions, I've kind of written down here in the bottom box here where it says crucial language. I think it's in there using an interface. Well, yeah, you have to have the specific wording combination therapy using an interface or combo therapy with interface so that someone isn't thinking there's surgery or something else being used. And that needs to be a signed order by the physician or healthcare provider of record. It could be a nurse practitioner, it can be a PAC. And also at that time, you want to have them definitely sign the informed consent. Now, we have an informed consent, which I've developed and it's gone through about 900 cases. It's a part of our deliverables. And a lot of you got to realize everything here is custom. You can't do an interface and they go, well, I don't like it. I want to return it. No, you've already been breathing through it and God knows what else. So there are no refunds. Once you start this, it is what it is. And most patients are fine with it. If they're not, fine, don't do it. But they're going to sign the informed consent or I don't treat them. Go ahead next. Here we have a lip guard. What this is dealing with is mouth venting. A lot of people are using nasal pillows or a nasal mask. That's just something that either covers your nostrils or goes in your nostrils. It's soft silicone. And you want the air to go through your nose and go down into your lungs, not basically go in your nose and out your mouth. And this has a relevancy with resting tongue level, which when you extrapolate goes into basically myofunctional therapy. As we went over in the past, the normal tongue level is the front part of your tongue, the anterior part of your tongue is resting between the first and second root gauges, gently laying up in that, gently touching the palate, and the rest of the tongue is at the top of the mouth. So that is a secondary barrier. So realize this, when the air goes through your nose, it's going to pass down, push your soft palate against the posterior area of your tongue. It's also when you bring the jaw forward, you're going to get the tongue up behind your anterior teeth, creating a secondary seal. When you don't have that seal, you're going to have air coming out the mouth, and therefore it's not working. So a lip guard, I think we have a picture of it later, something, in fact, I made a lip guard for a gentleman today who I've made it into an upper denture. So, and he's on bypass, or he's on the combo therapy. So we've gone over in the past, when you're dealing with a mouth breather, a low tongue level, you're watching the swallowing grimace. They have a reverse swallow pattern. You can, in essence, know that there's a higher chance you're going to need a lip guard. So assessing the need for a lip guard, everyone might just try to do this on their own. All right, you're going to have the patient just relax. And if the patient's tongue is at the top of the mouth where it should be, you're going to have them slowly slide the lower jaw forward, teeth over teeth, until the tongue goes behind number 8 and 9, creating that secondary seal. That's all you're going to need. That's the most protrusion you're going to need for this case. Some patients, you don't really even need to move them more than a couple millimeters. I most always start my patients out at an end-on position, incisal to incisal. I haven't used a George gauge since 1997. and over 6,000 cases. What is the one reproducible position in the mouth virtually always, unless it's a significant class 3 occlusion? It's end on, tip to tip. So starting at a tip to tip position, which is usually very comfortable for most people, unless there's significant class 2, at which time start from a centric occlusion position, have them slowly move the jaw forward, and when the tongue goes up behind 8 and 9, that's where you're going to basically not, that's basically as far forward as you need to come to prevent mouth venting. All right, you're subtly increasing the tone of the genioglossus, you're pulling it out of the way, and you're creating a secondary seal. Okay, let's go to the next slide. So when we're looking at CPAP pressures, this is just kind of a ballpark. School of Hard Knocks, do enough cases, you start to kind of get an idea of what's going on. When I have a real slender patient, and of course you don't want to blow people's brains out, I'll normally set pressures at 6 to 20. That means it'll go down as low as 6 centimeters of water and upwards of 20 centimeters of water. If you got a pretty heavy dude there, female or male, I've got one lady I saw last week. She's 5'6", 395 pounds. And it's funny, I've had patients ask me, how come the armrest on my chair is taped? And I go, well, when you have someone nearly 400 pounds putting their weight on it to get up, those screws in the plastic don't work. But when you start to have someone that's heavier or with a high AHI or a real low SpO2 oxygen level, I'll go 6 to 20 or 8 to 20. Now, once again, I always use a 4 centimeter ramp. So if they're at 8 and they go, it's just too high, you hit the ramp, drops them to 4. I found 15 minutes for the ramp time is kind of a sweet spot, but do it at 30 if you're comfortable with it. I've just found 15 normally works well. Occasionally, when you have a fairly heavy person and say, not real heavy, but heavy enough where you figure, oh, okay, it's not that much, I'll do 6 to 20. I've had patients say, I need more air. I'll jump it up to 6. If need be, I'll jump it up to 7. You want to make the patient comfortable. But these are just kind of ballpark areas that I kind of work with. Okay, I'll explain something later with this. Now we want to fine tune this. This is where we went over the ramp. I normally set 4 centimeters for 15 minutes. Actually, we might at some point, or I'll make a video actually with a ResMed or Respironic device, show you how to set the settings on it. Humidity, you're going to get, I have found that normally 3 is accepted. All right. And what happens is all CPAPs have a water tank, and you're going to want to have the water, set at a level so that the humidity goes through the hose and moistens the inside of the mouth and nasal passages, etc. I personally have mine on 5. Actually, sometimes on patients, when it's at 5, they'll get water drops on their mustache or on their face. But here again, I normally start people at 3. I don't go 3 to 5 immediately unless they're really dry. You want to do it slowly. What the EPR is, and expiratory pressure release, I believe the EPR is on the ResMed machines and the Flex is on the Respironic machines. They're the same thing. Factory set is at 8 centimeters of water. So when a patient's the factory setting is at 3. So what that means is if your inspiratory pressure is at 8, the machine factory set will automatically drop to 5. So it's easier to exhale for just comfort. If the EPR set at 2 and the initial inspiratory is at 8, the expiratory is going to be 6. If it's 1, it'll be 7. And if it's 0, you'll inspire at 8 and the EP is going to be 8. You're still going to fluctuate with whatever you need. It's just that whatever you're needing, you're not going to be dropping 3, 2, or 1. It'll stay what you should be having. The EPR is effective when you have patients that, one, have a very low oxygen. I've had patients where when you set them up on the CPAP machine. And we have great CT. All the desaturation indices are good, pulse rate's good, but their CT90, the amount of oxygen they're keeping in their body is low. If they have an EPR 3, I'll drop it down to 0 usually. Once in a blue moon, someone will say, that's uncomfortable. So I'll go, great. So we drop it from 3 to 2. Then give them a week or two, then I drop it to 1. And I'll do high resolution pulse oximetry just to check the oxygen as I'm going down with the EPR. But most patients, when you have it set at 0, they don't really complain, but occasionally they do. So be ready to go ahead and be able to adjust that as needed. Next. Okay, mastering the combination therapy setup. Let's go ahead and here. Once again, on your heavier patients, I like to go 8 to 20. On your thinner patients, go 6 to 20. And below and above 50 is just an arbitrary scenario. All right, refining the pressure and comfort features. You're effectively, I've had patients whose pressures are up to 21, 22. We took them down to 10. Usually on a BiPAP, I can pretty much turn 95% of the BiPAPs into CPAPs. And I've been very consistent with this. Overall, with combo therapy, I'm over 80% successful. Actually, I did the largest study. In fact, Dr. Essick was part of it through the University of North Carolina. I think that's ever been done using combo therapy. And overall, our success rate was around 67%, I believe, after a year. My office was a little over 80%. I think I was 81%. But I was the only office. I've got 12 CPAP units in my office. I have a different type of program where we are really a mother hen with this and really follow it closely. And so I think that's why we get a better result. And that's what I would like to teach the doctors that are interested in this. We set the ramp at 4 for 15 minutes. Humidity settings, once again, average is 3, but don't be surprised occasionally you have to go to 4 or 5. You're going to find drier people that are mouth breathers. So the expiratory pressure, this is the EPR. You're going to inspire at X. If it's set at 3, you're going to drop at 3 centimeters. You're going to expire at 5. Essentially, on all my cases, I start at 0 so that what you breathe in, you're going to breathe out. And if the patient complains, then I'll start to work it on that basis. Next. So the appointment, what do we do? Now, the beauty with combination therapy, my assistant, Cherise, she's probably done about 200 cases with me, maybe 150, I don't know. She does most all of this. I've taught her how to do it. The beauty with this is that you're there, you can train your assistant to do this. I charge $1,400 for the procedure. Insurance doesn't carry it. It's a cash item. And the point is that it's very amenable to an assistant to go in and do. You can train the assistant for everything, and you're there for any hiccups or issues for adjustments. So, and the assistants love it because it gives them something to do beyond aspirating and cleaning. So you're going to assemble the apparatus. We do the assembly in the laboratory. Now, on the stem of a TAP3 triple laminate, sometimes when you're going to put the interface on it, you have a metal stem that sticks out. Sometimes the machining at the end of that apparatus isn't quite as smooth as it should, so the interface won't slide on it easily. You need to be careful because if it is hard to put on and you try and put pressure on it, if it slips, you'll punch your patient in the face. I've done that once. It's not fun. You're not hurting them, but still. So what I'll do is take a polishing wheel, kind of a medium, and I'll kind of polish the end of that and or put a little Vaseline on the end of it, and the apparatus will slide on easily. Also, there's a little clear hole that the interface fits onto the stem with. Sometimes it's hard to see that darn hole, so I take a black marker and I circle it. And I did that today for a patient because otherwise, it's hard to see at times because it's all clear. So you'll assemble it. You'll take the facing off of the tap, put the stem on in the lab, assemble the interface in the lab. You bring it back to the patient, and you explain to them the full protocol of how to operate what the power is, what the ramp is. You're already going to have your settings there. Okay. And that we go over the daily care. Now, I think I'm older than most of y'all, but when I grew up, we had clotheslines. We didn't have dryers. Nothing grows in a dry environment. So with a CPAP, you have a water tank. Either with a ResMed, it slides in, you can pull it out, or with a Respironics where the tank opens. I always tell patients, remove the water source during the day so you have a clear movement of air through the machine, up through the hoses, and out the interface. Okay? Nothing grows in a dry environment. If you keep the CPAP closed on one end and the interface or your hose on the other, you're just growing fungus, mold, and everything else, and God knows what you're breathing. So your treatment appointment, your first appointment is you're going to lay the patient down after you've put the appliance on. You're going to put the appliance in, you're going to slide the interface over, you're going to put the nasal pillows in the nostrils. You're going to go ahead and manage with the initial pressures. You activate the ramp. If they complain at all, you hit that ramp immediately and you show them, because a lot of people will freak out when they get 8 centimeters of water. Not a lot, but enough. So many times, if you feel comfortable, just hit the ramp initially and just say, see, that's our start. And people go, oh, okay, that's not bad. Now, what you're really doing with combo therapy is you're trying to adjust the pressures low enough to be therapeutic but comfortable, and the jaw advancement minimal enough to be effective in preventing venting at the same time. Excuse me, I swallow air. But at the same time, you don't want to maximize any protrusion you don't need to. So you have less impact on the occlusion. Now, on the markers, what I found is you might look up, and it's not on the slide, it's called Bonhus, Bondhus, 0.5 millimeter. And then I believe that's for the adjustment. It comes in the kit because you're going to need a little longer screwdriver to adjust the appliance. The two screws on each side are different. I think they're 1.5. I'll have to look. I'm sorry I didn't put that on here. I'll find out, and we may send everybody an email tomorrow giving you the exact dimension, but it's Bonhus, Bondhus, because what'll happen is that they used to have the same screw size for the adjustment as the two screws on the side. It's just everybody was unscrewing their appliances accidentally. So they now have different sizes on the side and a different for the adjustment. On the side, if you try and use a little Allen wrench, by the time you're trying to finish tightening or opening it up, you're going to throw everything through the wall. With the Bonhus, it's got a tool about that long. It's very easy to screw things in and out. They're not expensive. In fact, today, because Airway Management was having an issue with getting the adjustment keys, I just bought 30 of them. They're $2 a piece. I got them on sale for $2.09. So instead of a typical Allen wrench, which is frustrating, I'm just going to give these to the patients. But you want to when you're doing that, you want to put on the handle, take a black marks a lot and put a little line there so you'll know where you've done a full turn. All right, timelines. When we do a case, we see 95% of our patients the next day. I want to know what's going on. So we'll seat the appliance, the interface. They come in the next day carrying their CPAP, everything. Usually Cherise puts them in room 4, says, put it all together for us. How'd you do last night? And we go over everything with them. About 50% of the patients are great. The other 50, it's another story. We've had patients videotape when Cherise is doing things. But it's your day one, you're going to want to see the next day. Sometimes it can be over a weekend, but you want to have follow-up. And you always want to document what occurred. Went over cases, fully answered all questions, explained protocol, or patient didn't show. Then about the next week to 10 days, we do the first night we do a download. I want to see what they did the first night. And like I said, this one case, they went from 82 to 4 in one night. 7 to 10 days later, we have them come in for a second CPAP download. They bring everything with them. Anytime between that time, if they have an issue with something, they give us a call and we get them in. Then we'll go ahead and see them in another 7 to 10 days for another download. Sometimes we'll do it another download beyond that, but always on the last one, I do a high resolution pulse oximetry. The reason for that, around 2014, we were just doing downloads and we get great results and we're great. One time I thought, what the devil? Let me just do a high resolution pulse ox with the patient. And the download was fabulous. The pulse ox is CT90, time above 90% or below 90%. He was like at 70%. I nearly died. I called the pulmonologist. He couldn't believe it. So we went ahead and put ancillary oxygen through the machine into the patient, got him controlled. He had COPD. So now we do high resolution pulse oxes, have for over a decade now with every last case. And on my progress notes, I send to the physician the last CPAP download plus the last high resolution pulse oximeter. And in most cases, that'll sustain the patient for any kind of follow-up sleep testing. Next one.
You're going to talk about the loaner?
Oh, okay, yeah. Oh, yeah, I didn't see the loaner. I've got a program in my office. And we've got something set up through TDSS where doctors can get uh, discounts on CPAP machines that they'll loan from their office, save you about $400 to $500. But what it is I have 12 CPAP units. When a patient comes in that needs it, we provide the loaner CPAP, and we have all and with this program we have, you'll get the chip and ability to do office downloads immediately on the patient. So we have the software for the download, the CPAP, we provide the hoses, the filters. Uh, all CPAP machines have like a little filter that fits inside. It's like a 3/4 inch by an inch and a half filter. I don't I don't care to use that. I mean, they're fine to keep the machine cleaner if you want. I get a big old circular bacterial filter I can pick up online for like $3, and I put it in between the interface and the regular hose. And I mean, I've had patients come back and that filter comes initially it's pristine white. I've had them come back gray to black. And I'm going, do you realize you're breathing this stuff prior to the filter? And it really upsets some patients because they never thought about that. But we give them the filter, we do the setup, and it's the process. We do this for 45 days. A lot of patients will turn around and go, boy, that's expensive plastic. And I go, no, you're providing a service. Actually, in the state of Texas, there are about 3 doctors that have ever done any real casework on this. So the fact that y'all can be able to start to learn to do this is going to put your office at a level that's above 98% of the other dentists in town or where you live that are trying to do oral appliances. You'll be able to treat anything essentially that comes into your office. And that's the whole point of what I want y'all to learn. So the clinical protocol for patient assessment in CPAP, you can go ahead there. We've gone over the lip guard. You're going to want to have, this is where myofunctional therapy, so much of its head bone's connected to the neck bone. You have to have an idea about myofunctional therapy, which deals with tongue level, which is going to deal with resting tongue level, degree of anterior protrusion of the mandible to be able to prevent mouth venting. Okay, if you see a patient coming in and they have that swallowing grimace where they're doing that when they swallow, they're crinkling here, you know automatically they have a low tongue level, which means to alert you about the fact of possibly they may need a lip guard. And once again, very simply have them move their lower jaw forward to see if that tongue ever moves up. Some patients can move their jaws far all the way out to maximum protrusion. That tongue doesn't go anywhere. That's a definite lip guard. Go ahead next. So here again, the assessment is going to be rest position, gently. A lot of patients will immediately move the jaw forward. Okay. No, you want them to very slowly move the jaw forward when that tongue goes up behind the forward position. And then you're going to go ahead with an elevated tongue position, in most cases, not have to worry about mouth venting. Now, it's not, I'm going to go over something that was in a prior study group, study club. A lot of your patients will say, well, I'm stuffy at night. I can't breathe through my nose. Some of y'all went through an earlier study club, but I'll go over this again for you. A very simple way to clear the sinuses. It's actually a part of what's called Buteyko breathing. Of I'm an international fellow on that. It's a very simple exercise. But if everybody wants to do this just for a second, just to go over the exercise for those that have already been done it, for those that haven't, they can learn it. Just have a patient relax. In fact, if you want to just relax, close your lips and slowly breathe through your nose. Inhale and exhale. At a normal end exhale, simply hold your nose shut. Then move your head side to side, only for distraction. You could walk in a circle, it doesn't matter. But the thing is, you hold your nose shut until you feel a medium size or medium degree of need to breathe. When you feel that, keep those lips shut and have them take a deep breath through their nose. And in most cases, it'll clear them up. Some real bad stuffy cases, it may take 2 or 3 times. When that's done, that's when you can put the nasal pillows in and they can breathe freely. It's also an easy exercise when you have a patient who's been told by an ENT, well, you need nasal surgery because you can't breathe because they're always stuffy. Have them do that exercise, and then the patient will go, I'll just say, hey, can you breathe good? They go, yeah. I'll say, well, if you're like this, you think you need surgery? They go, no. Now be careful when you do it because you don't want to have an ENT calling you, telling you about this. But that's a perfect segue for particularly younger patients to go in and get involved with myofunctional therapy. The basis behind that, I'm getting a little long-winded here, but I think it's important, is that nitric oxide is a vasodilator. When you're a mouth breather, you leave nitric oxide is produced in the lining of the sinus and also in the lining of the blood vessels. So when you're a mouth breather, you're bypassing all the blood vessels in the lining of the paranasal sinuses, and everything is vasodilated. It's just stuffy. Well, when you breathe through your nose, so when you do this exercise and you take the deep nasal breath, you're going to go ahead and pull all the nitric oxide through the ostium into the airway. And the tissue inside the paranasal sinuses is like erectile tissue. It's very responsive. As soon as you take that deep breath, everything's just going to shrink up and they're clear. As soon as they start to breathe through their mouth, they'll get stuffy again. So that's a simple way to if they want to use medications or nasal washing, that's fine. But this is just a very simple, natural way to clear a sinus. Okay. We're reiterating here again, when you're looking at pressures, and this is something that it isn't rocket science. You're not going to get in trouble with anything. You might want to try, but after 900 plus cases, this is what I've come across, is that on your heavier, more severe cases, you want to go 8 to 20. On your others that aren't, 6 to 20, ramp of 4. You might have some physicians go, oh my gosh, I never used 20. I go, well, great. What would you like your expert, your high level to be? And they'll tell you, and fine. Just kind of low key it. Next. When you're looking at patients that come in that have been trying CPAP and have failed, you generally want to go ahead and ask them. Most of them don't know. Sometimes it's in the sleep study. What were your prior pressures? People start going, oh, there were 8, or you see it's 8. It's a slam dunk basically with an appliance, in my experience. You start having patients coming in, they're going, well, my pressures were, BiPAP 15/10. That's a pretty good idea what you're going to be looking at. So it gives you an indication as to whether the appliance is going to be as effective, or an indication of potentially the need for combination therapy. A lot of times with patients, they'll come in with an HI of 28, or they go, I couldn't really stand the CPAP pressures. The pressures were too high. There's an old saying I found years ago: if you buy a car and it never worked, you never bought it, it was sold to you. And if you buy a car that's always been fabulous for you, it was never sold, you always bought it. So to a certain degree with this aspect, a lot of times I'll tell patients, let's try it with the appliance first, and then we'll go from there. Or you can say, you're really a high moderate, so I don't really want to go into it, but I'm going to lay a seed. There's a chance you're going to need something. That prevents the issue where I learned the hard way, where people go, well, I thought this was going to totally take care of everything. Why are you telling me now I need something new? Something more involved. So if you can go ahead and lay the groundwork for future, it's always easier. And if you do know pressures, you're looking at someone coming in with therapeutic pressures of 11, 12, 13. You're never going to meet that with the appliance. But as I tell patients, I'd rather have someone 80% control versus zero. Next slide. Optimizing the exhalation with the EPR. This is exceptionally important. I never knew this until about 2 years ago when I started working with Dr. Barr, who explained this to me. He's with Sleep. Uh, his group is our main source that we work with. He's fabulous. His company is SLIIP. It's all telemedicine. They mail the sleep study to the patient. He's boarded in pulmonary care, critical care, and sleep. The guy's really fabulous. And he actually takes the time to talk to you if you need him. Jennifer knows that firsthand. So, uh, so yes, this is what we're looking at. This is something really that virtually no dentists know about. I didn't know about it until about 2 years ago, and it has made a major difference for me. We can go with the next. The humidity is very important. And now the one thing too on I had this happen. It's only been once. It's kind of interesting. One of my patients was on the 1969 UT football team, football championship team, and I'm not mentioning names or whatever, but he's the only one I've had who always would fill the water container up too high. So he was drowning himself. You always have to make sure that they don't fill the CPAP water tank up too high, because what it'll do, it'll just suck the water up through the machine, wet the bacterial filter. They can't breathe through it. And it's happened to me just once, but here again, you know, things happen. Go ahead next. So really on the workflow, you're going to do the setup. My assistant does that in the lab. The seat, my assistant does that in the operatory. Setting the CPAP machines, I've taught her how to do it. She does that in the operatory. She goes over the protocol, and then we're going to see him the next day for immediate follow-up. Or if it's on a Thursday and you don't work Friday, you'll see him on Monday. And here again, this is where my assistant or I, depending on who's there, will set up the configuration on the CPAP machine. We can go to the next one. Prescription, reiterating here, the prescription is very important. Not a referral, has to be on a prescription pattern order. You're going to set the pressures. This is a recommendation for the pressures. You're going to want to put the EPR on the prescription or in your notes. Doesn't have to be on the prescription, but in your notes, you want to have what I do on mine, I'm still old fashioned. I do dual. I have an EMR, but I also do paper records. And I got to tell you, those paper records have saved me at times. But I make a note. I'll do RX, and when I have it, I put a strike through it. And when I get the RX for the combo therapy, I put a strike through that. So I know before that patient gets there, I've got all my documentation set. Go to the next. Let's see. This is where we were talking about if this is just an estimation, pressures, if it's 12, if it's, here again, if you've got someone with a AHI of 8 and I had a lady who's 5'2" and 395 pounds, and she had an AHI of 6. Now the appliance took care of her. And, but in cases where it doesn't, no, you're not going to start at 6 centimeters, I can guarantee you. So this is where judgment, this is just kind of a ballpark range for you. And honestly, if anybody out there ever has an issue with it, pick up the phone and call me. I'm more than happy to help you out with any of these cases as far as guiding you through things. We can go to the next one. Ramp time, you can set it at 6, 8. I've just found 4 minutes is very effective for hundreds of cases, and the same with the humidity at 3. EPR, we've gone over this. If I'm repeating myself, this is an awful lot of information. This is all new terminology, all new nomenclature. And this is something that, I've been doing for so many years, it's easy, but it could be a lot to take in one sitting here. That's why the module that we sent out, I hopefully is going to really help you with this. And if anyone has a question, pick up the phone and give me a call. The initial seating, this is all done with my assistant, which is fabulous. We can go with the next. The main thing, one thing on that aspect, you cannot rush this. In dentistry, essentially what you're really doing is wonderful dentistry, but you want to turn that chair. Okay. You don't want to take forever for one procedure. Sleep is a different ball game. When I first started out with this, I had that same mantra with dentistry. And what would happen is that we let them go. And my God, the number of times I got a call the next day, well, this is bothering me. Well, this is sensitive. Well, this is that or that, whatever. Actually, this last year I took operatory 4 and I put a dimmer on it. So we'll have patients, they go into that room, I'll put them on combo therapy. I lay them back, I turn the lights out and I say, go take a 20-minute nap. And this way, you never want to be accused of, well, they rushed me in and rushed me out. No. With sleep, you're going to take your time with that operatory, and the remuneration is good for it, so there's not an issue there. It's either you're going to do it that way, or you're going to see a lot of people the next day that could, with things that could have been dealt with in office. So you're going to go ahead and assemble it, seat it. It's really important to have an assistant, ideally, go over the protocol. But here again, you're going to want to know all this first. Therefore, your assistant isn't going to be telling you. You're going to be teaching your assistant it. And it's wonderful when a wife comes. You're going to have patients that have a little bit of cognitive issues, particularly with the elderly. We had one couple last month, frustrating. They come in the office, they're doing it perfect, all right, and he had a little bit of cognitive decline, and I don't know if she did or not, but they even videotaped it. They go home and forget everything. Then they come back and we go, you're doing it fabulous. And they go home and forget everything. So, needless to say, that was a failure. There wasn't much I could do about it. When you're dealing with patients that are with assisted living facilities, don't do combination therapy on a patient living in an assisted living facility without a private nurse virtually that's there at night. The living facility assistants, nurse, they don't care. They're not going to do anything. You need to have, for an elderly individual, if they're living at home, they have a daughter, a husband, wife, you need to have that personal help there. So we're going to seat the patient. You're going to activate the CPAP. You're going to manage the initial pressure. And once again, to start off with, it never hurts just to, in y'all's cases, since you're starting with this, you might just put the foot on immediately so you don't even have any like, oh my gosh, and go from there. With experience, you'll start to improve your presentation with it. You're also going to want to advance the mouth slowly. What you're dealing with combo therapy is you're moving the jaw just far enough forward to move the tongue out of the way to allow for the pressures to be therapeutic and comfortable. You don't want to come any farther forward. More is not better. In this case, treatment is not dose dependent. Okay? You can go back for whatever that slide is. You'll go back one. Yeah. All right. And what I do is I use full turns. When you're using, and here again, you can use any appliance you want, but there isn't a single appliance out there except the TAP 3 triple laminate that'll fit this particular interface. And when you're doing the appliance alone with a TAP 3 triple laminate, I do half turns, just kind of like so. Each half turn is a 1/4 millimeter. When you're using the larger screw that fits through the stem, I go with full turns. And that's why I'll put a little black mark so I know whether it's a full or a half or where it goes. Next. Okay. I allowed, like I mentioned before, you do not want to rush this case. When we have it all set there, I'll lay the patient back to their approximate sleep position. And if you can, turn the light out. If you can't, so be it. But the point is, I'll just say, look, just relax for 15 to 30 minutes. And this way, you're never accused of rushing people in, rushing people out. If it's the initial seating, it's a 90-minute appointment. If it's the existing patient and you're just converting it over, it's a 60-minute. And so, once again, you're being reimbursed enough for it, so there's no issues with the time. And the work doesn't stop when the patient leaves. You want to have that structured protocol. You're going to see him the next day. You're going to see him every week to 10 days for three more times. Sometimes it's less. You may get someone at the first or the second download, they're just going, I love it. There's no issues, fully controlled. Great. Go ahead next. But they always have to bring all their stuff. So the next day, 7 days, 7 days later, the transition. Now on the progress notes, I always send my last CPAP download to reiterate the high resolution pulse oximeter. And I type into the progress note, patient is doing exceptionally well, patient is getting used to, etc. What I also do is, depending on where they get the CPAP machine, my loaner is out for 30 to 45 days as a part of the fee. The patient is going to buy their own CPAP unit and return your loaner to me, or return the loaner to me or to you. So it's a loaner. I've had patients who have said, well, I thought for 1,400 you paid, I bought my CPAP. Nope, that's not the case. You also want to put your name on it. This is a true story. I'm glad I had my name on it. I got 3 in the morning one day. I got a call from Miami International Airport, the bomb squad. I had a patient who was flying back out of leaving America or coming, I forget which. They left my CPAP machine in the patient area, or in the waiting area. It was empty, but my CPAP machine. So of course the police saw it. Just CPAP, didn't know what it was. They brought out the whole bomb squad, had the dogs, the whole 9 yards. And I get a phone call because my name was on it. And I laughed, but didn't laugh, but I let them know what it was. And they said, thank you. They were not happy. And I had to inform my patient, please do not ever do that again. So you want to put your name on the machine, on the carrying case also. Okay. And oh, when you buy the machine, we've got you're going to have your loaner. We've really got 2 groups that we like to refer to. Of course, you can refer to whoever you want. One is through sleep if you're working with them. Another, if you're not working with them, but say through a physician as such. I have a connection with a company out in California that does dynamite, extremely capable and effective treatment for providing a CPAP machine. Next. When you have the interface, you're going to have the appliance, the stem, the interface that goes up. Then you're going to have the bacterial filter there, and then you're going to have the hose that goes to the CPAP. I provide a CPAP holder for all patients. It's a little classier. It's nice because you're giving them everything to take home. They're not expensive. They're anywhere from $15 to $20. And you have a connection between the filter and the hose here, or the filter in the CPAP. When patients have to go to the restroom at night, you don't want them taking everything off. I just say, look, you don't cram the hose up in there. You just gently put it in. So I just say, why don't you disconnect the hose up here and they can walk and go to the restroom. My granddaughter one day saw me and she called me an elephant because the damn thing was hanging down off my face. It is what it is. But that's the simplest way to simply disconnect, but you don't want to cram it in there real hard. All right. So we put them on a recall system. Once we've referred our patients back, recall systems are exceptionally important. One of my friends is an attorney. He's a diplomat with the American Board. He's also a litigation attorney for dentists. And recalls, if you have a patient that, and I see this all the time, I get patients in, I go, well, how old's your appliance? They go, 4 years. I said, have you ever seen your dentist? They go, no, they never called me. Well, it's to say year 2 and they were never notified. It's not really working. They weren't titrated properly. They run their car into a church bus, kill 3 kids. They're going to come back to you. And just like if you don't have a proper recall system, you're the doctor of record. So in our recall system, if a patient doesn't show, we document it. And your defense is we contacted the patient, but they never came back. So we go refer back to the physician, 6 months, and then yearly we see them. We replace the interface once a year. I sell them out of my office. We also provide the service for y'all where it's at a discounted rate for members that are with our group. And so I just, as a rule, replace the interface once a year. So to reiterate, once again, we've been going over a lot here. You want to go ahead and once you've set it up, lay the patient back. You take your time. The pressures are what you feel it should be. Make sure the patient has understood to the greatest that they can. Have them sign the informed consent. And what we also do too is on our informed consent, I'm pretty sure this is where it is. We have the patients provide at the time of delivery a credit card so that they do return those the CPAPs. CPAPs are about just under $1,300. They're not cheap. We get them at a discount. But once again, if a patient ruins it, breaks it, whatever, they're responsible for it. I've had no real issues though up to this point. So allow for acclimatization. You're going to schedule a 60-minute appointment for patient already has the appliance, 90-minute if they don't. You're going to see them the next day. Your first download, I normally do 3 downloads, maybe 4 sometimes, but on the last one, you want to do the high resolution pulse oximeter with it. Next. All right, so as we say, we've just gone over what we have there with completion. We have the loaner CPAP. My fee that I charge is $1,400. If you're a veteran, I'm a Vietnam era vet. As a VA doctor, I give veterans, I think we charge $1,100 for vets. We then go ahead and document all the settings. We have the proper referral and reporting back to the physician. So it's a 45-day program. We have the loaner CPAP, we have the bacterial filter, we have the interface, we have the CPAP holder, and I think it's a dynamite program in essence. And we really haven't had much pushback with it. Now, what's interesting with the complications here is I've actually had cases where too much pressure, and here again, it doesn't have to be a lot, but it depends on the patient's anatomy. I've had air coming out of patients' lacrimal ducts drying their eyes out. I had one lady with 7.5. She had air coming out of her lacrimal duct, tear ducts, drying her eyes out. It's 7. She didn't. Now, 7 was not fully therapeutic. It was significantly therapeutic. So we were able to get her significantly treated and everybody was happy. So that's for the dry eyes issue. Aerophagia, people don't like to walk around all day passing gas. And you're going to find, I've had 2 cases of dry eyes with that in 30 years, but it does occur. Aerophagia, you'll see that occasionally in patients basically because of the higher pressures. They're swallowing air like crazy. But like I say, particularly women don't like walking around passing gas all day. So this is something where using combo therapy, we can reduce pressure significantly. And I've never had a single case of aerophagia once we've treated it. In all cases with aerophagia that we have treated with combo therapy, it's taken care of it. So I think that's got us on the slides. And I'll kind of turn it over to Eric right now.
Yeah, so that was terrific. Thank you. I have set it up so that any of you can unmute yourselves and turn on your video if you would like to engage in a question and answer session. So we can do that right now. And I am wondering if we could get, let's see if we can get the, give me 1 second.
On my 2-day seminar, we go through combo therapy where we're actually going to have you do the whole setup on your system.
What we can do.
There's a whole setup on you.
Give me just a second. I can take care of this right now. Print share. There we go. And then stop share. There we go. So if you'd like to join in, does anybody have any questions for Dr. Dunbar? or any questions in general? Like I said, you can unmute yourself and ask the question.
I was wondering, Dr. Dunbar said that we are going to do a myofunctional therapy course. Um, e- so that we can set it up with the sleep protocols.
Yes, I've already written the whole myofunctional therapy seminar. Eric's going to go ahead and edit it. And we plan on hopefully having that all up by the end of January. I've got about 10 patients waiting for it to start, waiting for us to have that so they can start myotherapy.
Let me share a little piece in between is that so Dr. Dunbar has a course that he's written. We've got some really very good, very experienced myofunctional therapists who will be conducting the myofunctional therapy, and we will also have courses for your office that will be introductory and an overview and help you select some of your staff that can be uh, looking out for patients who may have myofunctional therapy issues. So in any case, we'll have that ready by, like Dr. Dunbar said, near the end of January, and launch that program early next year. But it'll include a couple of facets. One is the courses, the myofunctional therapy treatment for the patients, but also the course that Dr. Dunbar and the myofunctional therapist will share with you and your staff. Is that
Thank
right,
you.
Dr. Dunbar?
Yeah, you hit the nail on the head.
Thank you.
You're welcome. There he is. Can almost see you.
I'm sorry, I can't, my camera on this computer's not working, but I wanted to ask, do you have an interface with you? Uh, Dr. Dunbar, do you have one with you there at the desk that you can?
Oh, I don't. I don't. I should have brought one home with me.
Okay, when you said you replace the interface annually, what parts are you replacing? Like you're not replacing the metal rod that connects to the oral appliance, I assume.
All right, here's the stem. Sometimes people will tighten the nut so hard on the stem that it kind of puts an engrainment in the metal itself. So when a patient is asleep, you'll have more of a sliding back and forth. When that occurs, we'll replace the stem as a part of that. Uh, if we if that's not the case, we were able to talk with Airway to be able to go ahead and just have the hose nasal pillows. I didn't realize nasal pillows are, I think, $30 a pair. But what you'll find when you do enough combo cases, you've got extra nasal pillows. So it's always kind of a nice thing. It's like the lady today, I gave her 2 pair, which was $70 worth for free, just to say, here, take these. But yeah, it's the nasal pillows, it's the interface, it's basically everything but the stem and I think one other part. But you don't need the metal aspect with it at all, no.
How about replacing the hose from the CPAP machine to the connector to the
Right?
interface?
Okay, DMEs make a fortune off selling hoses. And I think they recommend every 3 months or 4 months to replace them. Once again, nothing grows in a dry environment. And so if you keep your tank open, you have full airflow. I just tell patients do whatever you want. I mean, I replace mine probably once a year because there's no growth. It's completely clean. If I start to see anything, I replace it. And that's the same thing with the interface. I'll have patients come in and boy, they're scrubbing like maniacs and they just tear them apart. But if they don't keep that water tank open, yeah, you might as well have a garden growing in there.
You mentioned a holder. Are you referring to one of these swing devices that you put above the bed?
Yes. Yeah. And I think in one of the previous seminars, I went ahead and had a show with it.
Okay.
And it's if anyone wants, I mean, I can send you a picture of it, but yeah,
It's in the manual, the image of that.
okay.
So
And for lip guard, is this the internal lip guard that fits under the lips, or are you talking about the one that fits outside the lips that was used a number of years ago?
Mac Thornton was getting ready to eliminate that, and I told him, you better not. And he realized, so that they're now making it again. So
Okay.
yeah, external lip guard.
External. Okay.
You put it in hot water, boiling water, just till it starts to slump, and then you go ahead and fit it over the face, just right across here, and then slide the interface over it. I made a new one for a patient today, and I charge $35 for the lip guard.
Okay. Thank you.
I'm going to share the screen and show the image of the hose holder. Is that okay? And then I'll stop here in a second, but you can see it right here. That's what Dr. Dunbar has in
You don't
intimated. So
side. It has to be behind the head.
I'll stop sharing, but any other questions?
So, Dr. Dunbar, I was wondering, people who are mouth breathers and we give the oral appliance like I delivered a tab 3, can they still do the lip guard just so that they're not hanging their mouth open, or the mouth tape is a better option?
Well, you're going to have the metal stem in order to do the lip guard. So, and here again, mouth taping is all you're doing is creating an artificial nasal breather, and you
Right.
3 inch one or the 1 inch 3M micropore tape, not air conditioning tape. I'm joking. I'm not joking when I say, not that you do that, Anshu, but I'm just saying I went and took a course and a speech therapist came in with a roll of air conditioning tape saying that's what she was using on her kids. So,
Yes, sir.
any other questions?
Do you find that your patients try to get their insurance company to purchase a CPAP machine for them, or do they try to buy one just like your owner?
What you'll find, all right, number one, Medicare, either the oral appliance or the CPAP. So they're not going to pay for both. Secondly, the regular insurance, I have found not all, and it depends on the policies, but a lot of the policies will pay for both the appliance and the CPAP because it's ordered by the physician. And but the actual interface combo therapy is not paid by any insurance carrier. There are no studies for it, Greg. I wish there were to be able to validate it. I don't think you and I live long enough to ever see enough studies to have it validated. Any other questions?
I have mine. He wanted to see the interface. I have it.
nice.
Let's see if I can get you on the screen here.
Yeah,
I'm gonna have to unblur the background if I can.
yeah.
Okay. Can y'all see that?
Yep.
That makes sense, Greg?
Yes. So where does the interface end and the hose that comes with the CPAP machine start?
The interface is this little bitty part.
Okay.
The screws are in there.
Go to the end of the hose. Yeah. All right. See the bacterial filter? Show them the bacterial filter right there. That's where you want to disconnect it on either end, but you don't want to have the patient, particularly on that rubber portion, the gray rubber. People will cram it in there like crazy. That's really where you want to disconnect it. And when they're asleep and tired, many times the elderly people can't pull it out. And so you just want to twist it in there just gently enough.
There's the nasal pillows. They go like this. And my staff has been using this as a demo, so I don't know where the bottom part of this is. It's been all over the office.
Yeah, I've got you want to have an interface just like what she has there to show people.
Yeah. So this is actually the top part.
Yeah.
Like I said, the bottom part is missing in action in my office right now.
Your nasal pillow is pushed in. You need to pop the little area out.
They're fine.
Well, no,
Okay, this thing is what he was talking about.
the CPAP holder.
Yeah, that hooks to the bed, and we can send them the Amazon link for that. And this is what the screwdrivers look like.
Yeah,
They're-
yeah.
A good background for them. They're long and skinny.
You want to get those, it's Bond House.
Mhm.
Get that for the side screws to adjust easily. If you want it to take the plate off and put the interface on.
And what he's talking about is you can't reach all the way in to adjust it without these longer ones.
Right.
That makes sense, y'all?
And the longer one comes with the interface.
That was all the demo stuff I could find really fast. But we can send them the link for on Amazon. We can send them that. So, yeah. Did that help?
Yes, yes, very much. So this is only going to work for the TAP 3. It would not work for the TAP with the hardware on the lower component.
I don't see how I don't see how it's structurally sound enough to do it, Craig.
Yeah.
So that's why once again I use the TAP 3 because I'd say 10 to 20% of my cases will go to combo therapy one way or another, and I don't want to have to keep replacing appliances.
Anybody else have any questions?
Well, wonderful.